problems that people can have. You can have problems with your emotions, right? Sad, mad, angry, whatever. Sad, mad, afraid. Even more subtle emotions, guilty, jealous, all those kinds of things. So people will come into treatment for emotional reasons, right? Their emotions are not like the way they want. Behavioral reasons, not doing what you're supposed to do, doing what you're not supposed to do, right? Not eating, binging, purging, all those kinds of over-exercising, right? We got a couple of people that are 5 and 6 hours a day exercisers. So behavioral issues, and then cognitive issues. The way that you talk to yourself, putting yourself down, saying all those sorts of things to yourself negatively. And normally I think about this as the kind of all of us think all the time, right? We have to sort of actively not think, right? You don't have to stop and go, what should I think about this? You're thinking all the time. Right? Kind of our stream of consciousness is kind of this idea of this kind of rolling series of thoughts and images and partial thoughts. It's not like we all speak in narratives. What do you think about this? Well, I think this. We have images, we have phrases in our head, but that's the kind of level, that kind of surface level of cognitions. We can't do anything, really, to fix the emotions directly. You can't push a button in your forehead and make you happy. If I push a button really hard, you'll be unconscious, but that's a different thing. Even drugs or antidepressants, anti-anxiety meds don't really work that way. They work indirectly, they affect neurotransmitter levels, which affect emotion. Which leaves us with cognitions and behaviors, which is where cognitive behavior therapy comes from. Right? We work with the 2 of the 3 things that get people into trouble that we can have some hope of influencing. Right? We can affect behavior, we can affect cognitions and thoughts. All 3 of these things affect each other. So, we've done these studies. People who are depressed, they've done really cool fMRI studies. Looks like we've got some neurobiology folks in here, because I like this stuff too. They've done some really cool fMRI studies with the same patients who are depressed in an active major depression and afterwards. And there are actually differences in with PET scans and fMRIs. Your brain works differently when you're depressed and when you're not, physically. When people go through therapy, their brains work differently when they're done. It's really cool. I tell my medical friends, haha, we can do the same thing you can do, right? When you think differently, you can talk yourself into being angry, right? You can sort of get indignant about something and get worked up and make yourself angry. You can also talk yourself down, right? You can talk your friends down if they're angry or upset or mad. That's sort of what we do, right? Emotions can change, or words and thoughts can change emotions. Behavior can change it. All right, so all this stuff works, which is nice, because all we have to do is work at one of these, and the other ones will tend to change as well. So we work with either thoughts and cognitions or behavior, or both, to affect change. And there's a sort of second level of this model, and it's the idea that all 3 of those things kind of filter down into what we call core beliefs. If you really get into, has anybody had sort of any kind of cognitive behavior therapy background, you read anything about it, or if you read a little bit? Yeah, so there's this idea, sometimes they call them schemas, sometimes they call them core beliefs. There's lots of different words for the same idea, but it's kind of our underlying assumptions about the world, ourselves, other people. We get into our own life experience, we get into culture. You can read books, watch movies. It's sort of we pick up kind of the rules of life, right? That's each of us has slightly different rules of life. We get them, right? You've got optimistic friends, pessimistic friends. You've got those kind of people who kind of come to the world or come to the table after a certain period of time, after you've kind of grown up with all these ideas. We now think that really to get long-lasting change, that's the level that has to be effective. So this kind of core belief level of change has to, and core makes it sound so very kind of deep and central, and it doesn't have to be that way. The idea is that it's those underlying assumptions, and this is where we think that over-concern with body weight and shape is. It's kind of this, it affects every single aspect of your life. It affects what you do, your behavior, it affects your cognitions, the way you talk to yourself. Because if someone says, hey, there's food back there, what do you say? It's, how do I avoid that? How do I not look at that? Right? So it affects that, and it affects your emotions. So stuff happens in the world that filters through our kind of core beliefs, and then it kind of filters up towards to our behaviors, our thoughts, our kind of running thoughts, and our emotions. To give you a sort of a good example, or one of my favorite examples, is a lot of people who have anxiety disorders have some sort of core belief about fear, danger. The world is a scary place. The world is dangerous, right? Maybe certain aspects of it, right? Dogs are dangerous, or airplanes are dangerous, or germs are dangerous. It's lovely that we have Ebola now because it makes all of our germ phobics sort of absolutely flip out. But that will affect, so the idea that the world is a scary and dangerous place can affect you. You're driving, when I was driving here, what if somebody, what if these cars hits me? What if a meteor crashes into me? You know, whatever, right? You can come up with all sorts of ways to be afraid. If you have that kind of central core belief that everything is scary and dangerous, things can be scary and dangerous, you start looking for it, right? You start to filter your world looking for those kinds of things. Same thing with concern with weight and shape. Unfortunately, we have a lot of stuff in our culture that can back that up if you're looking for it. If you're looking for reasons to pay a lot of attention to weight and shape, you don't have to go very far in our culture to see messages about weight and shape. Right? They're in all of our, I'm not blaming really the mass media, right? Because everybody gets the same message, and not everybody gets an eating disorder. I think it just makes it really easy if you have those sort of predispositions to end up having that be an issue. Right? So we work, and this is true because we know, I absolutely know this is true. We have people who have had multiple inpatient stays. If it was just about changing kind of your overt behavior, right? We put you in an inpatient facility, which is basically a really nice and well-lit jail, right? I mean, it's what it is. You can't go anywhere you want. Right? We feed you, we make you eat, we force you to go sit and talk about your feelings for 5 hours a day, and you know we do that for 2 to 4 to 6 weeks, and you're out. Well, if that's all it took to fix somebody, it was like sort of getting control over their behavior for a critical period of time, we would never see those people again. They come out, they do a month, they go, hey, thanks so very much, it's been great, you bring the next round in, you treat them for a month, they're out, and pretty soon we solve the whole problem. Doesn't work that way. And like I said, most people have multiple treatment stays with eating disorders. The kind of one-time cure we're pretty good at it, we're getting better, but there's a lot of people who relapse and come back, and that's because we think they probably didn't change that core belief level, that kind of underlying, if you will, notion that how they really filter the world is based on control of eating, shape, and weight. All right, so that's what we have to fix. Questions so far? Anybody have anything? I'll filter in the questions as we go.
Have you ever looked at, again, this is more of the neuro stuff, but
yeah.
have you looked at parallels between drug addiction or drug abuse and eating disorder, like kind of the dopamine and reward centers? I
mean, yeah, a little bit. I mean, they've done some stuff with naloxone and naltrexone and blocking reward pathways to see if it gets people. It does seem to have a little bit of effect on binge eating. The problem is that rewards can be really complicated, so it's not quite as simple as kind of the food tastes good, kind of pure kind of dopamine pleasure center kind of stuff. People have drawn connections between eating disorders and addiction, and I think sort of metaphorically it can sometimes be useful. But I mean, you know, you don't have like, I don't think we see the same kind of, I mean, we're all sort of dependent on food, right? It's like we already lose some of the metaphor when we think about dependency because you gotta eat. But some of the ideas, I worked with a guy, we had a guy in our counseling psych department, a guy named Matt Martins, who does alcohol research. And for a while we were looking at function of eating disorders and function of substance use. And we kind of back-ended into this. It was kind of almost an accident, of a side effect of one of our side finding one of our studies. That people who had both substance use issues, alcohol issues, and eating reported things like purging. We didn't know if they had a full-blown eating disorder, but at least a lot of eating disorder behaviors. Reported that they were doing a lot of using it as a way of escape, like the negative kind of dealing with anxiety. So that's now, we have in our newer models, we have the idea that people also will, once it gets established, people will typically binge eat, purge, restrict for emotional regulation. So that's kind of the next big thing. So it's kind of often starts as being about body weight and shape, and over time, this is, my best guess is it takes a couple of years. But over time, the function of that eating disorder morphs, and it becomes a general kind of stress-relieving function, avoidant function. Again, eating disorder symptoms go up during finals in colleges, not because you're not eating right during the finals, which it may be, but mainly because it's much more stressful. So that, and that kind of, I need to sort of escape the negative emotionality associated with finals and stress and classes. So that's why we see it go up. So there are some kind of interesting parallels between kind of some of the reasons that people might want to, in particular, drink. Because there's that kind of anxiety reduction hypothesis in substance use that people talk about. There may be a parallel with some of the eating stuff. So a little bit of that. Just a pure kind of model, kind of substance use addictions model treatment has not been worked incredibly well for the eating disorders. If you just sort of say this is an addiction, it doesn't tend to work as well. But kind of metaphorically looking at some of the kind of issues, I think it can be useful at times.
So you've mentioned groups a couple of times, and my sister's experience with inpatient has involved a lot of like group therapy and just interacting. And I know she's also mentioned a lot that like interacting with other people with eating disorders kind of has its own kind of like, they reaffirm their own eating disorder. So how does that work into like group therapy and inpatient where you've got all these girls who are like super obsessed with their weight and just comparing themselves against each other?
We call them on, and they call each other on, which is nice. And so the nice part is we have a rolling enrollment process, so people come in, we don't have like a lot of groups will work, like, you come in for 3 or 4 months, 20 weeks for a lot of CBT groups, and then you're out. So you do that, and then you get a whole new group come in. We have people who are further along who will absolutely call them out, on, because there is a little bit of that comparison with what I, kind of the underweight ones at first, like look what I can do. There's also someone, it works both ways. I don't ever want to look like that. So in some cases it's actually helpful because they sort of say, wow, if I let this keep going, I might end up really, being significantly underweight. So we do, there is some of that can happen, especially at first. But I think the benefits of a group process, where I can tell somebody 1,000 times, listen, if you try eating 1,500 calories a day is not going to make you gain 30 pounds. I promise. Like I can do the math and show them how it doesn't work that way, and eating a Snickers bar will not make you gain 5 pounds, which somebody's told me will happen. Like there's not 5 pounds of stuff in a Snickers bar, right? It doesn't even weigh 5 pounds. Like unless it's sucking calories in from the air, it can't do it. But there's that fear. And so telling them that, it's like, of course you're going to say that, that's your job. What's really nice is we have people who are on their way out who will say, I didn't want to listen to him, and I didn't want to listen to them, and I didn't want to do this stuff. I didn't want to follow my meal plan. I didn't want to do this stuff. Eating a regular dinner and not purging was the hardest thing I've ever done. But if you do it, you get better. And so a lot of times we have the benefits of other people who've gone through it saying that is 1,000 times better than I could ever say it. They are much more convincing. Right? And it doesn't mean they're always going to do it. So there is some of that kind of, especially at first, they come in and you can see them looking around and kind of, but I think the benefits really outweigh the risks in terms of doing treatment. And it is nice, again, because we've got people who come in with different diagnoses. There's someone who is sort of really underweight and someone who's not, and they're saying the exact same thing. Like, oh, I did that too, or you did that, or I used to do that, I don't do that anymore, but I did that. And there's this kind of notion that, oh wow, we look sort of on the outside very different, but we are really struggling with the same exact problem. That's also really helpful to sort of say, see, it isn't just, there isn't something unique about you if you are significantly underweight. It's the same exact problem. It just sort of, at times, you're just better able to do one versus the other. So I like groups a lot. They're probably 8 to 12, 6 to 12, 6 or so. Probably 8 to 10 being the best number. But you get a lot of benefits out of doing group, I think. And so we do CBT, we do cognitive behavioral therapy in the group format. And so they learn that CBT is a very educational kind of, I teach them basically the same stuff I've been talking about. I give them the model and say, this is how this stuff works. So they'll understand why we're doing what we're doing. This is my own take, is that people should understand why you're getting to do stuff, particularly if you're getting to do stuff that they don't want to do. They think it's kind of a bad idea and that will be really hard for them to do. So giving them some justification, like I'm just not making this stuff up. There's a real reason we're doing this. And here's the kind of theoretical model. At least makes it maybe a little bit easier to do. So what we have to do with them, is there any, I'm sorry, is that good? Any other questions about kind of just the background stuff? I'll talk a little bit about kind of how we actually do it real quick. So to affect thoughts and cognitions, we really do a lot of kind of classic thought monitoring. That is, we teach people to talk back to their thoughts. We teach people to step back and watch their own thinking process. And this is kind of the key skill, is to be able to step back and you say, what I say is that there's a huge difference between saying, wow, I'm fat, and wow, I just had a thought that I'm fat. Like there's a distance in the second one. If you're stepping back and watching yourself think, which gets us to these really weird philosophical notions of like, who are you and who are your thoughts? And we can have fun with that for a while. And psychology did come from philosophy, so we could probably hang out with that for years and discuss who was the thinker and who was the thinky and all that kind of stuff. But that skill of being able to step back and say, oh look, I'm thinking this right now. Someone said, do you want to go grab dinner? And here I go, and I start this whole thought process, so it just gets triggered. What am I thinking, and how do I kind of talk back to that, kind of talk myself down? And we have lots of strategies for doing that. It's one of the main strategies. Kind of works from that automatic thoughts. And the idea is if you do enough of that, if you kind of argue yourself back down enough times, it kind of slowly changes the way that this kind of core beliefs about over-concern shape the way. And the next part is dealing with the behavior. So we do a lot of exposure meals, we do a lot of exposure treatment. I like to call them behavioral experiments. Because the idea is that you use your own personal life experience as a way to challenge your thoughts about shape and weight. So I had, to talk about the calorie one of my favorite examples is I had a woman that was eating about 800 calories a day, and which is not much if you don't know your calories. It's pretty under eating. And so I said, listen, we're going to go to about 1,500 calories. No, we're not. Yes, we are. No, we're not. So we went back and forth with that for a couple weeks. I said, here's the thing. Try it for like a month and see what happens. And it took a couple weeks to convince her to give it like a 1 month kind of experiment. Because I said, I'm pretty sure you're not going to gain a ton of weight. I just know how this stuff works. She's like, yeah, but that's different. So she comes in. I said, how do you feel this week? And she said, I feel really bloated. I can look in the mirror. I'm bigger. This is horrible. I hate you. Get a lot of that. And so I said, okay, well, let's see how you're doing. So we weighed her, and same weight. Okay, well, they always, and now our patients joke about stealth calories. It's the ninja calories will come on, you hide, and they'll sneak up on you like 2 weeks later and get you. So we did it again. And she ate. She really did. I have to say, she gave her all the credit for really pushing the envelope. And she went ahead and she ate, she was pretty close to 1,500 calories a day from 800, which is a huge jump. And the second week, she came in, pretty much the same weight, I think 0.2 of a pound more. She was expecting to be at like 5 or 10 pounds heavier at that point. So I said, what do you predict? She said, I'm going to be like 10 pounds heavier. 0.2 of a pound, which is really error, right? It's kind of scale error. And so we did this in the third week. It actually went down back to her original weight. And she then accused me of having a fake scale in the trick. And I don't have a trick scale. Good idea, but I don't have one. And after 4, press the button. So after 4 weeks, I said, how many more weeks is it going to be before you realize that 1,500 calories is not a weight gain, sort of caloric level for you? And it took about 4 or 5 weeks for her to go, okay, I get it now. Because her own personal, me telling her that, again, I could have done that for years and she would have never believed it, but doing that kind of behavioral experiment, let's try, let's see. Okay, it turned out to be okay. And that was kind of one of the openings that worked for her. And another patient who was in high school who was convinced she wore really baggy clothes, a lot of body image issues. And she said, if anything that is at all ever form-fitting, everyone is going to be like one of those movies, the teen movies, where everybody stops in their lockers and stares at you as you walk down and there's like a spotlight on you and you go through, like every teen movie the outcast person has to walk through. So that's what she thought. It's going to be like, everyone's going to notice, they're going to be horrified by my body. They're not going to be able to hide it. I'm going to see it in their faces. It's going to be terrible. And again, it took a couple weeks for me to kind of talk her into doing this. I said, let's just try it out. You can always call your mom and come home, if it's really terrible. So, she was going to do this the day before she saw me. And so that she came in, and I said, how was it? And she said, 2 people said they liked my shirt. I'm like, that's it? She's like, that's it. I said, where was the horror? And, okay, it wasn't there. And that didn't solve the problem. Like, that didn't make her all better. But it let her open up to the idea that, wow, maybe I was wrong about this idea that people find me so hideous that anything that isn't completely sort of baggy and shapeless is going to drive people literally running and screaming out of the room. And so that was like the first step and part of the process. So we do a lot of those kind of experiments at all different levels. We do the body image ones. We'll do something called mirror exposure, so we basically have people stand in front of a mirror in increasingly skimpier clothing. They don't do this with us, they do this at home. The idea is that they learn to be able to sort of look at themselves because there's a lot of avoidance there, or they only focus on their bad body parts. And so the idea is you just sort of learn to evaluate yourself kind of neutrally. It actually works really well. We have them do that for body image. We have them do these other experiments about wearing kind of clothes in public and things. We do exposure meals. Because one of the things people will think is if I eat anything that's fried or, these days that has a carbohydrate in it or whatever, I'm going to gain a ton of weight. So we have them go through, and 2 days a week they bring their own food according to their meal plan. 1 day a week we bring food, and that's always fun because every once in a while we throw in pizza day. And I don't do the meals anymore because I did it when we first started. I don't do them anymore. So we have 2 people to do it. And I know it's pizza day when I can look at people's faces. They're walking down the hallway and they see the pizza boxes and they're, it's a challenging meal. But they'll do it, and they'll realize that they can have a piece of pizza. It is not the end of the world. They don't gain 15 pounds. They would never do that on their own, at least not until pretty far along. So we have to sort of say, let's see what happens, And so we do a lot of that about meals. You will be able to tolerate, this is a big one, the distress of eating food and feeling full. Right? That's a big one. So that physiological sensation of tightness against your skin, of like your pants and stomach distension. People will talk about their food babies and they'll say, I just can't stand this anymore. That you'll be able to get through that. It doesn't mean anything. It's called digesting. One of the problems with people who have eating disorders is, particularly if they've been restrictive, they get something called delayed gastric emptying, which is it really does take delayed gastric emptying, which is like it sounds. So instead of the normal kind of 2, 3, maybe 4 hours to digest, it can take them 6, 8 hours. So they really do feel full longer. It's a real thing. It's a really terrible thing to have to work through. It doesn't happen to everybody, and it doesn't usually happen for long, but it is relatively common. So they will come back and be like, I ate dinner last night, I'm still full the next morning, you know. And so we have to work them through that. So stomach distension does not mean the end of the world. I've had patients that would purge water, even though they know intellectually there are no calories in water. They just couldn't stand that feeling of being full. So if they drank too much water, they'd feel that feeling, and they would say that's intolerable. So depending on where the person is finding kind of the fear, we will work on, we have kind of built-in experiments, little behavioral experiments, exposures to do that. So everybody gets the food experiments. Like they work up to eat foods they're afraid of. They work to eat amounts of food they're afraid of. If someone is on a weight gain meal plan, they're going to have to gain weight. Like it's not one of it's not like a dog phobia where if you do it wrong, the dog bites you, right? That's the failure in like the dog exposure treatment. In this, they're going to have to gain weight. It's 100% certainty. For you to get out of here, you're going to have to do the things that you're afraid of the most. Let's see how you do that in a way that doesn't mean it's the end of the world. So that's kind of a built-in exposure for people who are underweight. So that's how we kind of deal with the behavior side of things. We help them to do stuff that challenges those underlying core beliefs about the importance of shape and weight in ways that are meaningful and in ways that get them to sort of say, oh wait, maybe I was wrong about this. Again, not that shape and weight are unimportant at all in controlling what you eat and wanting to feel good and look good and all that kind of stuff is not bad. It's just that you've sort of put a little too much emphasis on it. I'm trying to think. So handling the emotional distress of not having your favorite coping mechanism. Right? If once you get to use eating disorder behavior for kind of emotional regulation reasons, I'm taking away your #1 coping mechanism. Like that's not, and often we have to do that because you never, like I like to say, if that's plan A, you're never going to develop a new plan A until I take plan A away. Because nothing is better than plan A, right? Like that's the whole thing, is it works fairly well. So until we say you can't do that anymore, does it ever kind of force people to be like all of us do, is figure out how else am I going to cope with things now that my favorite way is gone. And then people can really kind of flail around for a little bit and struggle as they're trying to figure out a way to handle sort of coping with life distress without eating disorder behavior. So that can take a little bit of time. That's another big thing we do, because if I don't do that, we don't give people other coping responses and teach them other ways to do that, it's kind of a high rate of relapse, because next time they get stressed out, that's going to pop up as kind of an option. And frankly, it does. Over the first 6 months, that's kind of what we think of as kind of the high risk for relapse, because some of the stuff takes, really, if you put someone inpatient, it takes no time to kind of control their behavior, mostly, right? We're watching them 24 hours a day. They're still really good about doing it anyway. Every single person who has it, they say, yeah, I totally cheated. Like, they can't watch you all the time. I can get 20 jumping jacks in while I go to the bathroom. They can't see me. Or I'll wake up at 3 in the morning, do push-ups and whatever, or purge in the bathroom because they can't watch them. But they're pretty good at controlling your behavior, right? Changing that kind of core belief stuff takes a little bit longer. It takes months rather than days and weeks. So it's a longer period of time to get that to work through that. So we think kind of that first 6 months is really probably the kind of high risk time period. People will be abstinent. A lot of people are kind of abstinent and kind of do really well for a month or two, and then something throws them. The worst thing they joke about it, the worst thing you possibly say is, wow, you look great, right, to an eating disorder patient. Because what they hear is, wow, you look fat. You've gained so much weight. And so having to deal with sort of family members who are saying stuff like, oh, thank goodness, you're doing better. Can I say things about you now? Well, do I say nothing about your appearance? Because I think you look, we're so happy you're getting better. But if I say it, you'll translate that into, oh, now I'm fat. And they don't want to hear that. So we kind of have to work with kind of this, we talk sort of relapse prevention. That's going to happen. Someone's going to say something about your physical appearance at some point in your life from now on. And that can really trigger you. Even if it's sort of well-meaning, even if it's something that 99% of the population thinks sort of as a compliment, or at least neutral, right? This idea that gets interpreted, again, through that kind of weight shift filter as a negative. So those are really kind of our main techniques. We kind of work with thoughts to kind of change core beliefs. We kind of work with behaviors and behavioral experiments to change beliefs. And then we also can kind of go in sometimes and kind of work directly with the core belief once we've identified it, kind of just help people realize that this is a bad idea. And another way to think about core beliefs is think about them as life rules. And we're just teaching you, well, you're going to come up with different life rules. Like this one is not working for you. So it's not this kind of core belief, like this sort of monolithic thing. Just a different way to kind of look at and work through your life. And this way works better. So we sort of talk about, like, just try it out and see if it doesn't make you a little more happy. You go through the kind of adjustment period, see if you're not happier. See if it's much more, it's freeing to not have to think about this stuff all the time. And so it's not just the kind of weight and shape stuff, it's a more of a conceptual idea of, wow, I just feel so much more like sort of free to kind of think stuff other than kind of weight and shape and how you know, again, in colleges it's roommates, and they're like either young or older, they're not in school, it's home, it's friends, it's all that kind of stuff. Not having to worry about that is usually kind of a lever to be able to get people to feel better about that and be willing to kind of try this out. That is, we're getting close, right now. Right? Do we have other questions? I mean, I am happy to talk about this stuff more. Yeah.
So I have a question. So how would you approach somebody who has like a binge eating disorder, who's terrified that if they start eating, they just won't stop, and that's why they're restricting? That's
a really good one, because we get that a lot. Even not even sort of binge eating disorder, we get people who are underweight who say, if I start eating normally, I'm never going to be able to stop. It's just going to be, it's going to increase. We do a lot of behavioral experiments. Like, you know what, we're good at this. Give us a month, we'll watch it. If you're gaining 10 pounds a week, we'll help with that. We'll stop that. So a lot of times we'll say, you just have to trust us on this. You know, if you do this, we'll notice, like we're weighing you every week, we'll see it. And if you're really gaining this much weight, we'll be able to do something about it. You know, earlier on, you're not going to be 2 years from now, 350 pounds sitting, you know, somewhere. And which is what they, you know, they can sort of extrapolate this kind of, you know, major trend. So we kind of say, look, trust us on this. Give us a month or two. Let's see what happens. And, you know, we also say, look, you're really good at restricting. What makes you think you're suddenly going to completely lose that? You know, if anything, we're having to push you to gain enough weight at a rate that's helpful. So, you know, you've already got that skill set. And so but we sort of say, you have to trust us on this. And they kind of do.
How do you deal with people who do transition from anorexia to binge eating disorder and like cannot find that middle ground?
Yeah, I mean, that's what we have to do is help them find that middle ground. And it's relatively, I mean, what we typically see, it's happened, I've seen it happen. You go from kind of really underweight to really sort of out of control binge eating. We have some really good binge eating disorder treatments to kind of give people some sense of control back. And so we'll kind of tend to shift over to those kind of interventions. There's still kind of CBT treatments. But we actually have a pretty good hit rate at doing that. And what happens is often people have trouble because they make the transition. They've been so restricted for so long that there is a kind of overcompensation period where the body's like, calories, really? And they just sort of, they do get that kind of disinhibition and they find themselves gaining weight. So we do have to kind of walk it back a little bit sometimes, not all the time.
And how do you prevent that? Like once you get them to the point where they're no longer or get to a point where they're restricting during the day and then binging.
Yeah. We spend a lot of time with kind of meal plans and food plans and talking about how much you're eating and what those changes in calories or whatever, and saying, so what's going on and we'll do a lot of what's triggering it, you know. Because what we'll find is sometimes if they are restricted during the day, they're overly restricted. And so, you know, redistributing some of those calories more earlier in the day. Some binges are just driven by pure hunger. Right? You're just starving. So when you eat something, you just overcompensate. So we'll say, like, let's reapportion those calories more during the day and see if it doesn't stop the binges. And that's one of the main ways we can do that for that particular pattern.
Yeah, just going off that, do you ever find that patients' like satiety cues are completely thrown off by restricting for so long, and then, I mean,
absolutely, yeah.
Like, how can you kind of recover those cues? And like,
I would say it's probably more normal than not for them to have no sense of what hunger and it's like nothing, starving, nothing, stuffed. And all those subtle, because they've been ignoring and been actively repressing their own kind of satiety cues for long periods of time. What we tell them first is you just have to eat. You have to ignore, don't expect to feel hungry, expect to feel full, you're going to have to eat anyway, right? Which is, as you can imagine, a hard thing for a lot of them to do. It comes back, it really does. And as far as we know, people don't break that way. Those hunger and fullness signals, they're still there, they've just been ignored so long, they've been dampened down, they come back. Some fairly quickly, some have taken a little bit longer, but we almost all, I mean, every time I've ever seen somebody who reports that, they slowly but surely get it back. There's even a treatment called appetite awareness training that focuses on helping people, like while they eat, like they stop I mean, really, they stop fairly often and say, how hungry am I? And they start to rate it. And that's just a reminder to kind of help them start to regain those signals or start to pay attention to those signals again. So it is kind of a freestanding treatment. You can do, there's a whole workbook on it. But I really think of it as a good way to get people who've lost their signals and are worried about that, a way to kind of be able to say, on a scale of 1 to 10, I'm not a 1 or a 10 of like starving and stuffed, or really empty and stuffed. It's, oh, I can be a 4. I've eaten half my meal, how hungry am I now? And start to build something like that. So we do stuff like that. If we don't do full-blown awareness, appetite awareness training, we have people rate their fullness as they go through and have them rate their fear and all those other kinds of things as they go through. So that's a